Thank you for the invitation to present here today on something I thought I'd never say, but it seems like I'm beginning to even become an expert in eosinophilic diseases. And so I'd like to share some of what we do in Cincinnati and what I've learned over the last 15 months with you. But first, we're actually going to talk about Fpies. So Fpies, or like some of the Americans call it Fpies, is food protein-induced enterocolitis, and this is a non-IgE-mediated food allergic disorder. Although, as things always change in food allergy, people are now saying perhaps, we just haven't picked up that these kids have got some low-grade IgE floating about. But for now, it's considered to be a non-IgE-mediated food allergic disorder. It can lead to, it can be severe, it can lead to shock. There's currently no biomarkers to diagnose it, so history is absolutely key. And it's often associated with other atopic conditions. And for those of you who are on Twitter, you might have seen this morning I've been retweeting what they've been saying at the Canadian Allergy Society meeting on Fpies. And more than 30% of children with Fpies actually do have eczema. And, Niels will probably show his data later on as well, clearly showing that these non-IgE mediated diseases in the gut are often associated with other atopic diseases. Then in terms of the clinical features, the acute version of Fpies could be mild to moderate, but it can also have a severe aspect to it. And in terms of the mild to moderate one is these kids do vomit. They vomit about 1 to 3 hours after exposure, but they seem to be self-resolving. They may or may not have diarrhea, whereas the acute severe version, the kids often end up in A&E, or like they say in America, in the ER. They often need to be hydrated with IV fluids, and they have hypertension, and more often than not, they have diarrhea with some blood in the stool. Then there's also the new terminology of chronic Fpies, but Neil is actually going to discuss that term with you, and also the issues we have about whether chronic Fpies really does exist. So in terms of management, I think Fpies is almost the only presentation of cow's milk allergy where we are very clear that in all cases, or at least the vast majority of cases, the mother does not need to actually avoid the allergen during breastfeeding. And normally the children don't present with Fpies while they are breastfeeding. Now, one of the tweets from Sasaki actually said that breastfeeding prevents or protects against Fpies, but I wonder whether it's not just the fact that the allergen transported to the infant is just not enough to cause it, rather than necessarily being a protective effect. So I think there's two sides of the coins. Infants with milk or soy Fpies can actually react to other foods. So when I started to learn about Fpies, and as I was growing up with Fpies, I was initially told that if you have Fpies to milk and soy, you do not have solid food Fpies. And if you have solid food Fpies, you do not have Fpies to milk and soy. But actually, this has now been changed. So then in terms of the dietary management, infants are at increased risk of nutritional inadequacy. But the other thing about Fpies that's very unique compared to other food allergies is that we do recommend, or we do say that they do not have to take notice of may contain statements. That means that if a child has got Fpies to milk and they have to avoid milk, we will tell the people that they can actually consume products with a may contain statement of milk on the product. So they don't have to take any notice. And once again, the reason for this is the fact that children don't react to the allergens passed to them via breast milk. And so we're saying if they can tolerate those trace amounts of allergen in breast milk, then they should be able to tolerate the trace amounts of allergen that's present in may contain statements. Now, just that line is a whole lecture by itself because there's many things for and against to say. I mean, we do know that actually in terms of milk, 95% of moms consuming milk will transfer the milk allergen or the beta-lactoglobulin to the infant. But if she's actually consuming peanuts, only 50% of moms will transfer the peanut to the infant. So I don't think this is great quality evidence, but the best evidence we have at the moment. And then the other thing about Fpies is that really, we have sort of like a loose term about which formula should be used. And so the international Fpies guidelines that's coming out later this year, it's been submitted and accepted for publication, is going to say we use we should be using a hypoallergenic formula, so they don't actually make a differentiation between either using extensive or amino acid-based formula. Then high iron complementary foods is required because their weaning foods is often delayed. They're difficult weaners, difficult to get the food into them. We should monitor their weight and height. I will show you some data from Neil Shah and Roseanne Meyer's work. We have to focus on developmental and feeding skills. It's not surprising to see a 10-month-old baby arriving in an allergy clinic with Fpies. The first time the mom gave them rice, she was totally freaked out because the kid got so unwell and decided to just breastfeed and give no other solid. So quite often we've missed a lot of weaning milestones, and we have to spend a lot of time on developing those skills. The age and development of Fpies and development varies depending on the food being introduced and the country of origin, and I'll come back to that. And in some cases, the children may be sensitized to the food they've got Fpies to, so they may have milk Fpies, they have specific IgE to milk, and in those cases we know that the Fpies is going to be more persisting, and they will actually outgrow it much later. So then, in terms of Fpies and coexisting allergies, so we know, again, you know, from the data we have, and let me just say, there's really very few good quality papers on Fpies. In the majority of cases, it's just been case studies that's been written up, so the numbers of the studies are not particularly impressive. But based on the available evidence, we can say that children with cow's milk or Fpies relating to cow's milk, in terms of reacting to soya, the chance soy is about 30 to 40%, and reacting to other solid foods less than 16%. So much more likely to have soy Fpies in combination with cow's milk than actually having problems with solid food, although it does exist. In terms of soy, you have the same chances of being allergic or reacting to cow's milk and to solid food. But if you have solid food Fpies, like say for instance you react to oat or rice, then your chance of reacting to other solid foods is almost 50% and about less than 25% to react to cow's milk and soy. If you have soy to legumes, like lentils for instance, then your chances of being suffering from soy Fpies is very high, about 80%. And then if you have soy from rice and oats, other grains is about 50%. And poultry, soy Fpies to other poultry is about 40%. So you can see there the likelihood of reacting to other foods, because we can't actually check for cross-sensitization. Now, interestingly, the paper I'm quoting is the International Fpies Guidelines, and we do talk there about cross-reactivity. I actually think it's totally wrong. This is, you know, coexisting food allergies, but they're definitely not cross-reacting. So then we look at the foods implicated. So I just want to show this to you because we have written a series of papers which was published in Current Opinion and Allergy in 2014 on Fpies. And I think the good thing and the worst thing we possibly did was we actually got funding to make this an open access publication, which means that mothers can actually advertise these papers on their Facebook pages. They read the papers and they come in and they give me the perfect Fpies history, okay? Because what? They've read my paper. And then if I'm lucky enough, they're actually going to show me my own paper to prove me right or wrong. But just look here. So often mums will come in and they will say the kid has got Fpies to typical Fpies food. For example, string beans is a high Fpies risk food. Corn is a high Fpies risk food. Potato is a high Fpies risk food. But look at the numbers. Only one kid ever has been written up to have Fpies to potato at the time we did this review. 2 kids ever to turkey, 2 kids to corn. Banana, only 3 cases ever written up. So we have to put this in context when people tell you that the kid is reacting to typical Fpies food. So I'm not trying to say that it's not a problem, but the numbers are not actually that impressive. And at the time, we had about 100 cases written up with milk Fpies and 64 to rice. But this is the other problem with Fpies, is that if you do have Fpies, and particularly to these atypical allergenic foods such as rice and chicken and sweet potato and banana, it's very hard to actually avoid because they won't be indicated in bold, italic or in parentheses on a food label. So the other foods, just to show you, what I want to show you with this slide is that the foods implicated differ by country, and I don't think there's anything particularly special about a particular country. But for example, in Australia, soy is not actually used under the age of 6 months as it is not used in England. In America, soy is often used in under 6 months, and I think that's just the only reason we see more soy of Fpies in the States than anywhere else. It's just because it's given. Then in terms of the nutritional implications, again, this is summarized in this paper that I did with Mary and Gruch from Mount Sinai. It's a busy slide. I can't actually take you in detail through everything on this slide. So you're very welcome to download this paper. Like I said, it's open access. But again, in terms of milk, soy, egg, and fish, it always seems to be protein is the issue, but I will show you now from Roseanne's work in the next few slides that we don't struggle so much to get the right amount of protein into these kids. It's really the calories. It's trying to bump up their calories and get the right textures into them. And then in terms of the grains, again, here we have an issue with carbohydrates. We have an issue with carbohydrates in terms of rice. With the meats, it's again the protein, it's the zinc and the iron. With the grains as well, it's the iron, which is really why we've made a point of saying in the international guidance that, a focus should be made on, or, an emphasis should be made on giving enough iron. And then, of course, we have the sweet potatoes and peas. So looking at the growth implications, you can see here from Roseanne and Neil's work that often these kids have a low weight for age and a low height for age, but it can be corrected to a great extent by the sufficient dietetic input. And I took the slide out because of the sake of time, but feeding dysfunction is unpublished data from the Mount Sinai group, so Anja Novak should publish it, in the next few months. Huge problem with feeding dysfunction, but the biggest issue are worrying about eating. Both the parents worried about what the kids are eating, and the kids have their own concerns about eating, and that people actually consider meal times to be a nightmare. Nutrition implications, again, this is a typical slide from Roseanne, and a typical thing that she normally would say is that we do have the group in the middle that has enough energy and enough protein in their diet. Then we have the worrying group where there's insufficient intake, but we should not forget that there's also the group with the overconsumption. And we now even see it in our EOE data. I've just analysed our data hot off the press from our study on eosinophilic disease. And again, we saw the exact same things in the kids. So we have a group that's overweight, we have a group that's underweight, we have the group in the middle, and then the same pattern with protein and calorie intake. So as a clinician, I would say don't just focus on the group that's not eating enough, also focus on the group that may be eating too much. And then, the other question I always get from doctors is how do you wean a baby with Fpies? Which grains do you give first? Can you give fruit and vegetables? Should you be concerned about some ones? So again, based on very limited evidence, this is from the paper that I did with Mary and Gruch. And we sort of said, first of all, textures are important. We want smooth purees, we want to move on to mashed foods, and then we want to move on to minced and chopped foods. You can start with your green vegetables and the yellow ones, then go on to the other ones. In terms of grains, we start with millet and quinoa. We don't actually worry too much about corn, so that will be the next one. And then depending on whether there's rice or, oat Fpies involved, that may be the other ones. In terms of the meat and alternatives, we start with beef. Then we give lamb, chicken, and turkey. Soya-based yogurt we will only introduce after 6 months if they don't have milk Fpies. And then in terms of the pulses, we start with beans and peas. We acknowledge lentils may be a problem, in which case, again, soy is going to be a problem. So you're very welcome to actually look through the paper. I think it's given practical guidance on perhaps a staged approach. So we also wanted to have some case studies today. Again, I'm just going to whiz through this. It was a 7-month-old I saw with rice Fpies. The third day of eating rice, he had the projectile vomiting 2 hours after a meal at 7 months of age. Then he had an episode with just 1 lick of rice. So I've made that point because more and more we actually see these kids who say that they actually react, or the parents say the kids react to really trace amounts. So we may have to retract everything I said about traces being safe a few years from now. But at the moment, the current advice is still don't worry about anything which may contain traces. Then, no surprise, the kid reacted to yogurt at 9 months of age, and then the same happened to banana. So then, in terms of the hypoallergenic formula choice, the kid was breastfed up to this point, but the weight was gradually dropping off. Mom wants to supplement breast milk, so which formula shall we choose? We know that amino acid formulas are definitely indicated in terms of growth. Both ESPGHAN and IACI guidelines and RACMA recommends that. There was no anaphylaxis. The kids got multiple food allergies. This kid didn't have atopic dermatitis and also didn't react to proteins via breast milk, but still ticked 2 of the boxes, indicating that an amino acid-based formula would be the best option in this case. And then, of course, as a dietitian, it's not just about choosing the formula, it's then making sure that the kid actually gets all the textures in they should. So, really focusing on soft and cooked and chopped food, making sure that they actually get that hand-eye coordination. We spend a lot of time, particularly in the EOE clinic, designing, menus with 101 foods if the kid can only eat apples, broccoli, and let's say grapes, and we tell them to freeze dry it and to puree it and to bake it in the oven and to deep fry it, because we try and get, at least with the 3 foods we can give, different textures. So basically here as well, you can make oven roasted broccoli for crunch, you can do freeze dried apples to get some crunch in, and then we also talk about meats, we talk about dissolvable solids. So in England we say bite and dissolve. The NIH prefer dissolvable. So things like quinoa, millet, we do crackers because, again, it's sort of like a dissolvable food, and then pastas and pancakes to make sure we get enough grains in. We know that quality of life is affected. So Matt Greenhalgh, another friend of ours from Colorado, he's spending a lot of time with Audrey Dunn-Gunville looking at quality of life. And as you can see, normal upbringing in particular and nutrition are 2 of the main concerns they have, as well as eating out in restaurants. So that really, in a snapshot, is Fpies. So the kids can have the chronic version, which Neil is going to deal with. They have the acute version with the vomiting 1 to 3 hours after eating it. It can often be the atypical foods. The foods don't cross-react, but they often coexist. You've got to choose the right formula, and then you've got to give weaning advice. So eosinophilic esophagitis. So eosinophilic esophagitis is defined as a chronic immune antigen-mediated disease characterized by clinical symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. And you had a brilliant talk already from Glenn Ferruta about this. Interestingly speaking, in the NIAID guidelines that came out in 2011, EOE was actually defined as a mixed IgE and non-IgE mediated disease. But we have now followed this up with a position statement from the IACI group to say that actually it's not a mixed presentation. EOE is just a non-IgE mediated disease, and IgE testing should not really play a role. I'm a co-author on the paper. I think it's early days. We may need to learn a bit more, but for now, it seems that it's more non-IgE. The history is not particularly important to try and identify foods because the symptoms actually, unlike Fpies, has not got a classic presentation after a certain amount of hours. So really these kids can have symptoms days after actually starting to eat the food, which really complicate trying to find the foods that's causing it. And then symptoms often don't correlate with the clinical pathological findings, and I'm going to show you that in my case study in a minute. There's different diets we can try. Elemental diets, test-directed diets, 1 food, 4 food, and 6 food exclusion diets. Now, I didn't do this for the sake of today, but normally on this slide, I then say, do not trust the studies. We are really learning about EOE so much, and I think in each one of these, you can actually pick holes in it. Like test-directed diets, we say they're on average about 50% effective, but some use specific IgE, some use component testing, some use patch tests, some use skin prick tests. So really we're comparing here apples with pears. One food exclusion diet, so far only cow's milk has been tested, but many of these kids were on medication concomitant to actually avoiding cow's milk, which made it more difficult to interpret. But actually, great study by Dr. Tom Platz-Mills and Elizabeth Irwin, and fascinating data they show on IgG4 in this study as well. Then for food exclusion diet, it's classically supposed to be milk, egg, wheat, and soy. But if you're actually looking at Alfredo Lucendo's studies from Spain, wheat he classified as all grains, and soy he classified as soy and peanut because peanut cross-react with soy. So it's not really classically a 4 food exclusion, it's much more. And 6 food exclusion, I'll show you on the next slide, is classically milk, egg, wheat, soy, peanuts, tree nuts, fish, and shellfish. So the big debate is whether we should avoid just wheat as wheat or whether it's wheat, rye, and barley. And we've done a study across different sites in the States, which are called the Seeger sites. And then we looked at an international group from the Indana group. And it's very clear that in Europe, we avoid wheat, rye, and barley. And in America, it's wheat only. So quite often, again, European and American studies cannot be compared head to head. But, practically speaking, it does make a difference because if you're avoiding wheat only, they can still have all these beers. This is just the short list of all the beers in America that's wheat-free. But if you were avoiding wheat, rye, and barley, then many of them would not be suitable. So practically, it has huge implications for the patients. Then, obviously, after you've avoided the foods, whether it's 1, 6, 4, or whether you've done an elemental diet, you now have to put the food back. So you can actually identify which food is causing the EOE and whether it's all 6 of them. Now, I wrote this paper with David Fleischer, which was just published last week in Annals of Allergy. And with this paper, actually, there's a 5-minute video clip. So if you feel like having a good laugh on a Saturday night, if you've got nothing else to do, listen to me. My kids say, Mum, you are terrible. But so the issues with the diagnostic phase is how many foods should be reintroduced before the next endoscopy? How long should you introduce each food for? Our clinical practice is if we reintroduce, let's say, wheat and they become symptomatic, we stop them from having wheat. We wait until symptoms resolve and then start a new food. Lucendo, for example, let them continue with the food which make them symptomatic until he can scope them. So again, we're putting a task force together from the IACI group to actually try and standardize this process. Should we do the allergenic foods first? Should we do the low allergenic foods first? How long each food? How often should you scope? How many foods between scopes? There's many questions that we don't know. This is how we introduce foods over a 12-week period at Cincinnati Children's. It's normally 3 foods, and then we scope after 12 weeks, 3 foods, and then we scope after 12 weeks. But, it looks always better on paper than it is in clinical practice. Quite often the kids don't want to eat the apple they're supposed to introduce, or we don't get enough wheat into them, or they start vomiting from the milk, and it can make this process very messy. So then if we talk about level of avoidance required, when we get to the management, so once you've identified the foods, now you've got to manage it. So we have lots of questions about level of avoidance required. There's issues with nutritional deficiencies, growth and development, again, feeding skills and quality of life, as we've seen in Fpies. So in terms of EOE, we do not know whether they should avoid things that says may contain traces of milk, egg, wheat, and soy. We just don't know. It's impossible to do the studies. We don't know whether they actually may tolerate baked milk. And again, perhaps Dr. Irwin and Dr. Tom Platz-Mills is really leading the field, I think, in terms of milk avoidance and EOE, may be able to give us that answer before anybody else. But this is a very small study from the team in Harvard, where they showed that some people with EOE can actually tolerate baked milk. And that was 11 out of the 15. But again, this is the only study, and it was actually just a letter in JACI. As dietitians, again, we need to look at the allergens, and which nutrients are involved. I'm not going to spend too much time with this because I'm worried Trevor is going to give me the red card. Growth is always an issue. I've already explained. We see the overweight kids, we see the underweight kids, we see the normal group. Feeding skills, they have huge feeding disorders. And like Glenn already said, it's a swallowing issue, EOE, and these kids have learned feeding behaviors. They eat slow, they pick in how they eat. everything gives them tummy ache. You know, sometimes you just don't know how you're ever going to get this kid to eat. Their quality of life is affected, and the more foods you take out, the more their quality of life is affected. So really, in future, you know, we need to learn more about how long foods need to be avoided for, which foods need to be avoided, what threshold levels can be tolerated. We need to look at long-term outcomes of giving them all these funny proteins. These kids live on quinoa and hemp. It's really good for them. We need an elemental drink for the adults. We also need to measure patient adherence better, and perhaps electronic food diaries can help. And so this is a very quick case that I'm just going to show you a few things. It's a 5-month-old. He was vomiting with eczema, growth filtering, sensitized to many foods with IgE-mediated symptoms as well. Despite my intense input, we were totally at a loss, and the kid was not getting any better. So we actually referred him to the gastro team, and actually this is a busy slide, but the point I'm trying to make here is, of course, the eosinophils was above 15, but it's about the bigger picture. So you really need a good pathologist and a good gastroenterologist that can actually look at the whole picture of what the esophagus look like. Then, despite him already being on a diet, we added in some budesonide and some PPI, and quite often the guidelines don't say this. They always say choose one. Do PPI first, then choose steroids or diet. But quite often in clinical practice, the kids are managed on all three. So in this case, we had the kid on diet, budesonide, and a PPI. Lo and behold, he came back a few months later, and the eosinophils are up back to 1. Now, this is great, you know, huge success story. What happens symptomatic? He's not vomiting, but he's still not really eating. He still hasn't got any appetite. We're struggling with food. We're struggling with textures. When I actually look at his growth chart, again, you know, we're sort of like getting there. I actually, so you're actually one behind me. Sorry, I didn't realize that. So when we look at the growth chart, we were not doing too great. He wasn't gaining too much weight, but actually his height shot up. So I actually phoned Roseanne and said, Roseanne, we wrote this paper on managing malnutrition and cow's milk allergy, but I'm doing a very bad job in following our own advice. And she said, actually, Carina, you're doing great. Weight's not really shooting up, but height's getting there, and that's what we really wanted. And then really, you know, there are some inflammatory processes perhaps going on. Again, this is the paper that I did with Roseanne on why they're not gaining weight. But at the moment, if you look at his current diet intake, he's at least having 3 meals a day. He's slowly getting more variety in his diet. His calorie intake has gone up, but we want him to top it up with a little bit more of a high-calorie feed. But he's slowly getting there. So his eosinophil counts are under control, but getting him totally symptom-free, getting him to eat, getting him to gain weight is a much longer process. So this is just the people I wanted to thank. I know this has been a whistle-stop tour for everything, and Neil, I'm sorry if I've overrun, but we will do questions afterwards. Okay.